Today I'm going to talk about coronavirus. Okay. So here is the picture you have seen from maybe many times. So the title you can see now is a plural. Coronaviruses is because it's not one virus, it's a large group of viruses. And they're named for the spikes on their surface. So on the screen from the picture, you can see that there are some crown-like spikes. And in Latin, corona means crown. That is where the name comes from. Coronaviruses have existed for many years, and many of them cause very mild illnesses. But some coronaviruses can cause very severe diseases. So in 2002 to 2004, there is severe acute respiratory syndrome called SARS. That was caused by one type of coronavirus, SARS-CoV. And in 2012, there's Middle East respiratory syndrome, MERS, caused by MERS-CoV. And this year, we have the coronavirus disease 2019, we call it COVID-19. It's caused by SARS-CoV-2. So the virus is called SARS-CoV-2 and the disease is COVID-19. Okay. This virus is a novel virus. Some of you may have heard another name. It was temporary name, 2019 novel virus. Why do we call it novel? Because it is a new strain that has not been previously identified in humans. So based on this sentence, you can tell that we haven't seen this in humans, but how about animals? Is that possible that viruses can be transmitted from animals to humans? Actually, there is a term, spillover. It's talking about transmission of a pathogen from animal to a human. And there's even a New York Times bestseller book about spillover. Okay. And for SARS, the SARS-CoV been transmitted from bats or civis to humans. And for MERS, it happened in Middle East. So there are camels. They can be transmitted from camels to humans. Ebola virus from bats to humans. But for this new virus, SARS-CoV-2, we still don't have enough information yet. So still need to be determined. This is a rapidly evolving pandemic, and we will be receiving many new information. And those new information will help us understand this virus and the disease more. So now you already know that there's a difference between the virus name and the disease name. They often have different names. Many of you are familiar with the name HIV and AIDS. And HIV is the name of a virus, human immunodeficiency virus. And AIDS is a disease, it's called acquired immunodeficiency syndrome. Viruses actually, they are named based on the genetic structure. And they're named by the International Committee on Taxonomy of Viruses. So for SARS-CoV-2, you can see that the name is very similar to the virus that caused the SARS in 2002 to 2004, is because they are genetically related viruses. And the disease, they are officially named by WHO, World Health Organization, in the International Classification of Diseases, we call it ICD. The name was officially pronounced on February 11th, 2020. And before that, they used a temporary name. They don't only name those diseases, they also generate new ICD-10 code. Probably you haven't heard of those codes before, but every time you see a doctor, actually, if they give you diagnosis, they will submit a code to insurance company. So you can see now we have 2 ICD-10 code specifically for this COVID-19. It helps the healthcare providers to identify those patients who to record that they are actually infected by this virus and they got diagnosed with the COVID-19. This code has been effective on April the 1st, 2020. So it's very, very new. So you can see when the new virus and the new disease come out, lots of people work together. We're working as a team to move very quickly. The virus structure is very useful to develop diagnosis tests, vaccines, and medicines. Because it's very important that we'll be able to detect who got infected. Here you can see there's a picture. It's an image by the transmission electron microscope. And you can see here, those are the spikes of the coronaviruses. So those microscopes, they can see very, very tiny particles. And they will fire electrons and help you to see those images. There's another picture. Actually, that one look at the structure of the spike protein in that crown, in the corona. And the name of the microscope is a little bit different. You can see there's another term, cryogenetic electron microscopy. It's because you will put this virus at very low temperature. You freeze it, and then you fire high-speed electrons and take tens of thousands of pictures, and then you combine those pictures together to have a combined 3D image of the protein. You can see here they also have different color to indicate different parts of the spike. And the green one actually is the part of spike that will bind to the host cell. And when the disease transmits to humans, actually the whole cell will be human cells. And the scientists, they have found out that it's much easier for this new coronavirus, SARS-CoV-2, to bind to human cell compared with the 2002 to 2004 SARS-CoV virus. That's why it's much faster for this COVID-19 to get transmitted compared with the SARS. So you can see now scientists have been working very hard and very quickly to identify the structure of the virus. And it helps them to develop test kit, to develop vaccines, and then treatment for the disease. Well, currently, actually, there's no existing FDA-approved or cleared test. Because this virus is new. It's a novel virus. Everything is new. So we have to start very quickly. On January 31st, Health and Human Services Secretary declared a public health emergency in response to this COVID-19. So here's the picture that he's signing this public health emergency declaration. So this declaration enables new tests to be authorized under the emergency use authorization, which means that even though the tests have been approved by FDA, because approval procedure will need clinical trial data, but now it's a pandemic, it's an emergency, so we have to act very, very quickly and people need to work together to prevent the spread of the disease. So now under this emergency use authorization, people will be able to utilize the new tests that are developed, which have been approved by the FDA. You have heard about CDC a lot. CDC is the Centers for Disease Control and Prevention. They are the first one to detect, to draft the test in the US. There are also private sectors who develop test kits, like pharmaceutical companies. Okay. And the FDA will determine if the test provide accurate result. It's very important that the test results are accurate, because you want to make sure that you capture all the people who got infected by the virus. But at the same time, you don't want to detect everyone who are not being infected by the virus. So in epidemiology, we have two terms. One is called sensitivity. The other one is called specificity. Sensitivity is about when a person actually infected by the virus, you want to make sure that the test gives you a positive result. And specificity is among the people who haven't been infected by this virus. We hope that the test will give you a negative result. So sensitivity and specificity gives you the percentage of test positive and test negative. So in ideal case, we want 100% sensitivity and 100% specificity. Because it is a public health emergency, so everyone works as a team. So you can see CDC works hard to develop the first draft of the test kit in the United States. Now also pharmaceutical companies, they also react very, very quickly. So the first FDA authorized test kit is from a pharmaceutical company called Roche. So within 24 hours of receiving the application, we already authorized the use. You can see, again, everyone worked as a team, work very, very quickly together. Okay. The first step of doing the diagnosis test is to collect samples. And there are different types of samples acceptable. So there's a preferred choice of the swab-based testing. So you can see here, there is a picture showing how the swab test samples collected. So it needs to be done correctly in order to give you correct answer. So most centralized labs, they use RT-PCR. You may have seen this from the news. That is reverse transcriptase-based polymerase chain reaction. So it can be used to detect very specific genetic material within the virus. In this case, it is the SARS-CoV-2, which caused this COVID-19. For these types of analysis, they can analyze multiple samples at the same time. For example, they can allow for as many as 96 patient samples to be analyzed at the same time. Even though it takes hours for us to see the result, but it allows the centralized lab to analyze many, many samples at the same time. Many of you may have heard about the backlog of the test result. That is mostly related to you have to send the samples to the lab, transport to the lab, and also wait to be tested. Okay. There's also fast point of care tests available. Some of you, if you follow the news, you may heard about the 5-minute test for the test positive and 30 minutes for test negative. Those are considered as the point of care test, can be performed in a clinician's office. Those are very good for performing tests on single patients. So after we finish talking about diagnosis, well, so how about when people get test positive? Is there any treatment? Do we have any medicines that treat this COVID-19? Well, however, there's no existing FDA-approved drug for COVID-19. This is a new virus and a new disease. It happens so quickly, so there's no existing approved drug. In order for FDA to approve a drug, we need to have data from randomized clinical trials and show us that the drug is safe and effective. But it takes time for company to gather information to conduct clinical trials. That's why right now there's no existing approved drug. But we can authorize drug use under the EUA, which is for this emergency public health condition. There are some off-label use approved drugs. So what is off-label use? For example, many of you may have heard about hydroxychloroquine sulfate or chloroquine phosphate. They have already been approved by the FDA, but not for treating COVID-19. The hydroxychloroquine sulfate approved to prevent and treat malaria due to mosquito bite. So in the US, we don't have that many of malaria patients, but if you travel to other parts of the world, like Southeast Asian, you will see more cases of malaria. This drug can also be used to treat some autoimmune disease, such as lupus or RA. Chloroquine phosphate is also approved for prevent and treat malaria. So you can see now we already have existing drugs, but they're not approved for COVID-19. So if they are used for COVID-19 treatment, that's called off-label use because the label they're not indicated for treating COVID-19. But because we have this pandemic and people have to react very, very quickly, so FDA issued the EUA to allow those drugs to be donated to the strategic national stockpile so they can use to be treated to certain hospitalized COVID-19 patients. Because those drugs have been approved, so we know that they are safe. And we're hoping that those drugs can be beneficial to treating those COVID-19 patients. And the FDA has also created a coronavirus treatment acceleration program on March 31st, 2020, that enables FDA to react very, very quickly to the request about coronavirus treatment. Because now, again, we are during a COVID-19 pandemic. This is a public health emergency. And you can see every day we have many, many new cases. So it's very important that we work as a team and act very, very quickly. That's why you can see people have been working together. The pharmaceutical companies, they have been developing new drugs. And also the healthcare providers, they have been investigating whether their existing drugs can be used to treat COVID-19. And at the same time, the regulatory agencies such as FDA is working very hard to accelerate this authorization. And if you check a website, clinicaltrials.gov, and search COVID-19, you can find out the number of clinical trials that are undergoing related to COVID-19. So when I search today, there are 410 studies that are undergoing. So you can see lots of people are working very hard and trying to find treatment and also vaccines for this new pandemic. Vaccines for COVID-19. Vaccines, they can greatly decrease the risk of infection by safely developing immune to the disease. So you can see here, we have a term word safely. This is very important that we make sure that vaccine is safe because we don't want people to get infected by the disease. Okay. So many of you may have heard of measles, but I guess you don't remember that when you took the measles vaccine, because that was administered when you were very little. That is a very highly contagious disease caused by a virus. And the vaccine, one-time vaccine is called the measles, mumps, and the rubella vaccine, MMR. It's safe and effective. So when 2 doses were given, the effectiveness is about 97% preventing the measles. And if a person only got 1 dose, it's about 93% effect. So you can see previously, if we have about 100 people supposed to got infected, and after 2 doses, only 3 of them got infected. It's called 97% effective. It's very, very effective. It can help us decrease the risk. And prior to 1963, there's no measles vaccine. At that time, each year in the US, we have millions of people developing measles. But after that, you can see because people have been using this measles vaccine very widely, we have led to a greater than 99% reduction in measles. That's a very big success. But how about COVID-19? Well, because it is such a new virus, it's such a new disease, so there's no existing FDA-approved vaccine for COVID-19. And these vaccines need to be very specific for COVID-19. So before I showed you the structure of COVID-19, and that structure helps develop new vaccines. And we cannot use influenza vaccine to prevent COVID-19. So even though each year we do have many influenza vaccines, I think most of you receive influenza vaccine each year, right? And are you aware of that there are different types of antigens in that vaccine? So we have the trivalent vaccine, influenza vaccine. It has the H1N1 subtype A, H3N2 subtype A, and also B Victoria. So this year, the predominant strain, influenza strain, is B Victoria. Okay, and in 2009, it was the H1N1. We also have the quadrivalent influenza vaccine. In addition to those 3, we also have the B Yamagata. Okay. And the vaccine needs to be specific. That's why we have to develop this for this COVID-19. Right now, there are also ongoing clinical trials, but it takes time to develop vaccine. And also there's a difference between the vaccine and the treatment, because you can see for the treatment, we can use some existing treatment for off-label use. They're not approved for COVID-19, but because people are being hospitalized and this is such an emergency, we know that drugs is safe, want to treat them with the existing drug to see what can help those patients. But for vaccine, it's for prevention. And they're administered to healthy individuals. So we have to make sure that it's very safe, and at the same time, we'll make sure that it's effective in preventing the disease. And also, we cannot use other existing vaccine to prevent this from happening. So it takes longer time to develop this vaccine. So basically, you will see that for this new vaccine, for this new virus, and for this new disease, There's no existing vaccine that can prevent this from happening. And we don't have approved drugs. But of course, we are exploring the usage of some existing drugs for off-label use. So what is the effective way to prevent you from having the disease? Social distancing, right? Have you heard about the term R0, basic reproduction number? That tells you how many cases of disease on average an infected person will cause, right? So here is a plot I copied from Wikipedia. So you can see the first one about Ebola, the R0 is 2. You can see one person on average infect 2 people, and the next round 2 becomes 4. So that's the powers of a 2. Many of you familiar with powers 2, so you know that 2 to the third power is 8, 2 to the fourth power is 16, 2 to the 10th power is 1024. And the SARS R0 is roughly 4, so now you can see one person infect 4 people, and the next round 16. So that goes much quickly because 4 to the 5th power is the same as 2 to the 10th power. It's 1024. Anyone can guess what is the R0 for measles? That is a highly contagious disease. So for the measles, R0 is 12 to 18. Which means that one person on average infect 12 to 18 people, and then if you have a 2 round, is 144 to 304. So that's really, really high. 100 years ago, we have 1918 influenza pandemic, and millions of people died from that pandemic. And that R0 is 1.4 to 2.8. How about the COVID-19? So based on the most updated information from CDC, the estimated R0 is 5.7, and we have usually put a range, 95% confidence interval, 3.8 to 8.9. But of course, because that's a new virus and new disease, new information will keep coming in. So later you will see that they may adjust this estimate. So now you can see for this COVID-19, it got transmitted more quickly than the 1918 influenza pandemic because the estimate R0 is 5.7, around 6. That is much smaller compared to measles, but for measles, we do have vaccines. For the COVID-19, there's no existing vaccine. So I have to make sure that we keep social distancing so that can greatly reduce the risk that you got infected. So here I copy the language from CDC official website. So I have to make sure that you stay at least 6 feet, which is 2 meters from other people. Don't gather in groups, so no parties, and stay out of the crowded place and avoid mass gathering. I think most of you did very, very well. And I want to thank you for keep social distancing. Okay. Any of you familiar with this graph? That is the information from Maryland Department of Health website. So every day around 10 a.m., they update information from Maryland. So you can see today, the number of confirmed cases in Maryland is 6,185. They also report the number of deaths, hospitalization, number of negative test results, and also release from isolation. They not only tell you how many data we have, they also tells you the new cases in the last 24 hours, because it tells you how fast it grows. The map is the map from Maryland. So for the student, I want all of you to get familiar with the Maryland map and get familiar with your neighboring counties and your county. Here in Howard County, this 299 indicate Howard County. And then 1,214 indicate the total number of cases in Montgomery County. And the 203 is Carroll County. 233 is Frederick County. 979, Baltimore County. 505 is Anne Arundel County. And 1,476 is Prince George's County. So if you follow this website every day, you will see the change and see the spatial distribution of the number of COVID-19 cases. So now I want to ask you, that tells us about the number of cases. Is there any information that we're missing from this graph? Is there any additional information we need to know about the widespread of this disease? Oh, oops. So one thing we're missing is the denominator, the total number of population each county. Because when you look at number, you will see, oh, Montgomery County has a much higher number of confirmed cases. Well, actually, it's also because in Montgomery County, their population is about 3 times the amount of Howard County. So in Howard County, it's roughly 300,000 people, and in Montgomery County, it's roughly 900,000 people. So when you look at the number, you also need to find out what the denominator is. That can help you understand the rate, the incidence rate of this disease. That's a very important term that we use in epidemiology. So here is the real world data that you will see every day. Well, since today we don't have that much time left, I think for next week, we'll discuss how to utilize real world data to inform us about this COVID-19 outbreak. So I think I'm going to stop here to see whether anyone have any questions, because next week we'll continue with the discussion about this coronavirus and the COVID-19 outbreak. So I'm going to skip those slides and show you some resources that you can see. So the first link is the CDC coronavirus website. The second one is the Maryland Department of Health official website. And the third one is the Howard County website that tells you the updated information every day. And again, keep social distance, stay safe. So now I want to, we don't have much time left, so I want to see whether anyone have any questions. If you do, you can unmute yourself and ask questions. So our meeting will end in less than a minute. You can also type your question in the chat or save your question for next week, since we're going to continue talking about coronavirus and the COVID-19 outbreak. Okay. Okay, I see some question. Is it any way to learn the location of positive cases nearby? Well, since I have less than 1 minute, I don't think I will have time to answer this question at this time, but I will save the question for next time. And next week, the same time, I'm going to focus more about how to analyze the data. So we'll discuss more details. Okay. Also ask what website do you go to see how many cases? The website I see is, I use the Maryland, the second link in the slide. Yeah, we'll publish these slides on the Kappa HC website, so we'll be able to see and find the link.